Children everywhere are fascinated with what can possibly fit into their little orifices. Where do parents go when there's something stuck up there? That's right, to see you and me. Are we ready? Foreign bodies in the head and neck. Let's do this.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. A foreign body in the head and neck may be a benign nuisance, but some foreign bodies, or where they end up, can be as urgent as any condition we see in children. Our job is to figure out what happened, what's the culprit material, where it is, and hopefully how we can get it out safely. It can be tricky. Parents may not recognize the situation right away. They may discover it just by chance, and of course, once they know about it, anxiety and fear of complications take over, along with a palpable urgency to get it out now. Some of the most common objects are what you would find around the house, like coins, toys, balloons, magnets, insects, crayons, hair accessories, beads, pebbles, erasers, plastic bags or packaging, or the deceptively dangerous button battery. Now, before we go further, foreign body removal is a procedure. Remember your non-pharmacologic techniques. Set the scene and control the environment. Limit the number of people in the room and the noise level. Minimize crosstalk. The focus should be on engaging, calming, and distracting the child. Use guided imagery. Tell them a story. Sometimes you'll also need gentle, reassuring restraint. When in doubt, and if possible, use a smartphone to distract. Many of these procedures go well with non-pharmacologic techniques only. You may have to add some nitrous oxide or some oral or intranasal midazolam, depending on the situation. Most of these procedures are not painful, but they can be distressing. Just mild anxiolysis may be all that's needed. Of course, there are times when a full ketamine sedation is needed. Size up the room. What stage of development is the child in? How are the parents handling this? Can they be of any help? How delicate is the extraction going to be? Even a simple procedure in a problematic patient may need a deeper sedation. Trust your gut, but always start with a base coat of non-pharmacologic methods. All right, let's talk about the ear. First, a little review. The lateral 1/3 of the external auditory canal is flexible. Try it right now. Go ahead. Wiggle, wiggle, wiggle. The medial 2/3 of the external auditory canal is fixed in the temporal bone. Where they meet is usually where foreign bodies get stuck or where you end up scratching the delicate skin if you're sticking things in there. With any foreign body, especially in the ear, ask yourself, is it graspable or non-graspable? In a study by DiMuzio et al. Entitled Emergency Department Management of Foreign Bodies of the External Ear Canal in Children, they found that if the foreign body was graspable, there was a 64% success rate. The complication rate in the graspable objects was relatively low at 14%. If the foreign body was non-graspable, there was only a 45% success rate. Now, you wouldn't think that's so bad until I told you that in the non-graspable objects, there was a 70% complication rate. In other words, if you can see it and grasp it and you feel it's worth a safe try, then go for it. If you can't see it or can't grasp it, we may need to call our ENT colleagues. I don't feel bad about this. They have the best tools available, and I'm happy to have them take a look. All right, let's talk bugs. If there's an insect in the external auditory canal, kill it first. They will fight for their lives if you try to dismember them or take them out. The patient can become terrorized by the noise and the pain. It's excruciating to have a flailing cockroach in your ear. To kill the little critter, or let's just say lull them into a final sleep, you can use lidocaine jelly or viscous lidocaine at 2%, or lidocaine solution at 2 or 4%. Lidocaine has been shown to paralyze and kill the bug faster than any other agent. You can also use isopropyl alcohol or mineral oil. After the ordeal and after irrigation, you'll want to give a topical antibiotic drop as prophylaxis. That bug has been scratching his dirty extremities into your patient's ear canal. Mop up the mess with good irrigation after extraction and antibiotic drops for a few days. What about vegetable matter? Food, plants, beans, peas, the usual. Do everything you can to avoid irrigating it. The organic material will swell against the fixed structure. It'll cause more pain. And irrigation will make it that much harder to extract and may increase the risk of infection with organic material. A few pitfalls for foreign bodies of the ear. Failure to inspect after removal. Is there something else in there? Failure to assess for abrasions, trauma, or infection. Is there any break in the thin skin of the ear canal? Then, if you find it, give prophylactic antibiotic ear drops. And lastly, the law of diminishing returns. The probability of successful removal of ear and foreign bodies declines dramatically after the first attempt. If it isn't a dangerous object like a button battery, you have time to deal with this as a referral as an outpatient. Okay, let's talk about the nose. The high-yield review here is where things tend to get stuck. The number one place for nose foreign bodies is up the nares at the junction of the middle turbinate and the nasal bone. That's where nasal cartilage, a mobile structure, and the nasal bone, a fixed structure, meet. Seeing a pattern now? Another place for foreign bodies to become lodged in the nose is in the inferior portion of the nasal pharynx. So the child sticks something not directly up the nose, but directly back, way, way back, towards the occiput. Now that's commitment. The sticking point is in the inferior nasal pharynx at the level of the hard palate and soft palate. Of course, be wary of the foreign body that started in the nasopharynx, but is now lodged behind the soft palate at the junction of the nasopharynx and oropharynx, because it can end up as an airway foreign body. Some pearls for the nose. Consider using topical analgesics and vasoconstrictors to reduce pain and swelling. They may also improve tolerance of and cooperation with the procedure. Use 0.5% oxymetolazone spray and a few drops of 2 to 4% lidocaine. Just be aware that the foreign body may dislodge if you're shooting something up there. Be ready for the precipitous development of an airway foreign body. If you have no idea what's up there, go ahead and get a plain film of the skull, of the face, or of the neck, not to make a clear diagnosis, but to rule out a button battery insertion. Pitfalls for the nose. Beware of unilateral nasal discharge in a child. Strongly consider retained foreign body. Don't push a foreign body down the back of the patient's throat where it may be aspirated into the trachea. And lastly, be sure to inspect the palate for the vacuum effect. Small or flexible objects may be found on the roof of the mouth, just waiting to be aspirated. A quick story on that. I saw a toddler once in triage. The mother's chief complaint was choking that resolved. The 2-year-old and his mother were visiting another family member who was hospitalized. Upstairs, he had a brief choking episode, and mom brings him down to the ED just to get checked out. Now I go in, I say hello, play with him for a few seconds, listen to his chest, and get him to open his mouth. Nothing. But as I finished looking at his mouth, and as I was withdrawing my pen light, my eye caught a brief glimpse of something that refracted the light. I look again. At the roof of the mouth was a colorless, transparent piece of plastic pegged up against his hard palate. Luckily, the little boy was cooperative, and luckily, triage was right across from the resuscitation bay. I bring him calmly but swiftly across the hall, get my McGills, and snatch away this piece of plastic that at this point was flapping ever so slightly as he inhaled and exhaled. It turns out it was the plastic backing of an EKG lead that he probably found somewhere upstairs. The vacuum effect. So, we've got the ear and nose down. Let's talk about foreign bodies in the throat. Before we go further, remember that a foreign body in the mouth or throat can precipitously become a foreign body in the airway. Foreign body inhalation is the most common cause of accidental death in children less than 1 year of age. Go to BLS maneuvers if the child decompensates. For infants under 1 year of age, whether they're conscious or unconscious, back blows and chest thrusts. For every infant with an unstable foreign body, put his head down and give him 5 back blows between the scapula, then 5 chest thrusts on the sternum. Reassess, repeat as needed. For children older than 1, it depends if they're conscious or unconscious. For children 1 year and up who are conscious, use the Heimlich maneuver. Stand or kneel behind the patient. Reach under his arms, make a fist, and point the thumb of the fist on the abdomen below the xiphoid process. Cup your other hand over your fist and perform 5 upward and inward thrusts back to back. Repeat if the airway remains obstructed. Alternatively, if the patient is supine, open the airway, and if the object is readily visible, remove it. You can also use abdominal thrusts. Place the heel of one hand below the xiphoid, interlace the fingers, and use sharp, forceful thrusts to dislodge. Be ready to perform CPR. For children 1 year and up who are unconscious, just do CPR. Start CPR with chest compressions, and don't worry about a pulse check. After 30 chest compressions, open the airway. If you see a foreign body, remove it, but don't perform blind finger sweeps because you can push that obstructing object further into the pharynx and damage the oral pharynx. Attempt to give 2 rescue breaths and continue with cycles of chest compressions and ventilations until the object is expelled. All right, let's talk about the essential anatomy for foreign bodies in the throat. Most esophageal foreign bodies in children occur at the level of the thoracic inlet. This more or less corresponds to the level of the cricoid, a few finger breadths up from the sternal notch. The foreign body usually gets held up by the hard-working cricopharyngeus muscle, otherwise known as the upper esophageal sphincter. Other anatomically narrow sites include the level of the aortic arch and the lower esophageal sphincter. If you suspect a foreign body in the hypopharynx or throat in the stable child, you can start with a chest X-ray. In the stable child, remember that chest films are limited. 80% of airway foreign bodies are radiolucent. Look for unilateral hyperinflation on expiratory films. This is air trapping. If you see, for example, a coin en face, that's that flat circle facing you, it's in the esophagus, lodged at the thoracic inlet. How do we know this? Well, the pliable esophagus accommodates a flat coin against the flat aspect of the vertebra. If you see the round flat object with its side turned towards you, then it's likely in the trachea. Most importantly, be aware of the double ring sign. This is when you have what looks like a coin, but you can see a concentric circle just in the margin of the outline. You're seeing the larger and smaller terminal sides of a button battery. This is a critical finding. Always look for it because a button battery lodged anywhere in the body is an emergency. The electrolyte-rich mucosa conducts a focal current from the narrow negative terminal of the battery, rapidly causing burn, necrosis, and possibly perforation. It only takes an hour or so to cause a dangerous burn that may lead to perforation. Emergent removal is required. Button batteries that have passed freely into the stomach will continue to pass on through. They do not require emergent intervention. They can be followed closely. Okay, it's not a button battery, it's not a sharp object, and it's not a long object. What now? If there's no obstruction, consider reevaluation the next day. You may wait up to 24 hours for passage. Sharif et al. Found that coins found in the mid to distal esophagus all pass successfully within 24 hours. What conditions prompt urgent removal? First, size. For infants, objects smaller than 2 centimeters wide and 3 centimeters long will likely pass the pylorus and later the ileocecal valve. For children and adults, objects smaller than 2 by 5 centimeters will likely pass the GI tract. Next, character. Sharp objects have a high perforation rate, up to 35% according to the American Society of Gastroenterology. Sharp objects need to come out. Some pearls for foreign bodies in the throat. History is essential. Believe the parents and assume there is an aspirated or ingested foreign body until proven otherwise. If there's a history of choking, the patient needs to be asymptomatic with normal plain films for you to consider discharge. If there is a history of choking, the patient needs to be asymptomatic with normal plain films for you to consider discharge. If there is a history of choking and the patient either has persistent symptoms even a little cough, or he has an abnormal x-ray, no matter how subtle or doubtful, the answer is bronchoscopy. Cohen et al. Found that of 142 patients with a history of choking evaluated at a single-site university hospital, only 61 had a foreign body. Of the 61 patients, the majority, or 42, had abnormal physical exams and radiographs. 17 had either abnormal physical exam or an abnormal radiograph. Only 2 had normal physical exams and normal radiographs, but both had a history of persistent cough. The bottom line here is this: a history of choking plus either an abnormal exam, abnormal films, or persistent symptoms, get that child his bronchoscopy. We just can't tell otherwise. There is a not ideal middle ground. For patients with some residual suspicion of an aspirated foreign body, either this is mild initial symptoms or improving symptoms, a possibly abnormal chest x-ray, low but finite risk, and say you have limited backup or limited resources, you could consider chest CT with virtual bronchoscopy and digital reconstruction as a rule-out strategy. Again, not ideal because of the radiation involved. It's a risk-benefit. Outpatients who have passed a small and non-concerning object into the stomach or beyond do serial exams and have the parents observe the child's stools. You can use polyethylene glycol 3350 or Miralax if there's delayed passage. Some pitfalls in foreign bodies in the throat. A single household magnet will likely pass through the GI tract, given it's not too large, as we mentioned earlier. 2 or more magnets, though, are big trouble. They can attract each other through the walls of the intestine, trapping bowel between them, causing transbowel wall pressure necrosis. Not all magnets are created equal. Neodymium magnet toys, also called buckyballs, were recalled in 2014 in the US, but they're still out there. They're shiny and they're cool to play with, until the child ingests them and trashes his gut. These are very powerful magnets. They're very small and they're never just one ingested. They have to be removed to avoid bowel wall ischemia. A small but important detail. Patients should avoid wearing belt buckles or metallic buttons in case of a single magnet ingestion while waiting for the single magnet to pass through. All right, we've talked about the what and the where of foreign bodies. Let's talk about how to get them out. Some tools of the trade. The curette. If the small foreign body is in the lateral 1/3 of the auditory canal, you can probably get it out with a simple curette. You can manipulate hair beads if the central hole is accessible. Use the rigid curette with an angled tip. Steady your dominant hand by placing your hypothenar eminence on the child's zygoma or his temporal scalp to avoid jutting the instrument into the ear canal with sudden movement. Small, gentle moves are best. There's a large selection of disposable, simple, and even lighted curettes on the market. The right angle hook. There are many variations of ENT tools available, but one that I keep in my Go pack is the day hook. I use its 90-degree angle to pass the hook behind the foreign body to snag it. You can make your own day hook if you like. Straighten out a paper clip and bend it to a right angle at about 2 to 3 millimeters from the end, using a hemostat, for example. Be sure not to use the kind that has the friable, shiny, metallic finish, because you can probably leave that behind in the ear canal. Now remember, if the foreign body is completely lodged in the external auditory canal, then any trial of a hook will just cause trauma to the ear. Alligator forceps. Alligator forceps are best for grasping soft objects like cotton or paper. If you're dealing with smooth, round, or oval objects, it's just not what the alligator is hungry for. When using them, be sure to get a firm, central grip on the object. You want to avoid tearing it into smaller, less manageable pieces. Remember, look before you grip. Be careful to visualize the area you're gripping to avoid pulling on and possibly avulsing soft tissue in the ear canal. Cyanoacrylate. Apply cyanoacrylate, or also called Dermabond or Surgiseal, to either side of a long wooden cotton swab. I prefer to use a small drop on the cotton tip side because I feel like there's improved grip and molding around the object when you apply it. Immediately apply the treated side of the object in the ear canal in a restrained patient. Steady your hypothenar eminence on the child's face to avoid dislodgement of the cotton swab with sudden movement. Apply the treated swab to the foreign body for 30 to 60 seconds to allow bonding. Then slowly pull out the foreign body. Revisualize the ear canal for other retained foreign bodies, or maybe there's an abrasion or some kind of ear canal trauma there. Did you just make a mess? Did the cyanoacrylate drip somewhere, or did the swab stick to the ear canal? No problem. Use 3% hydrogen peroxide solution, or use acetone. Pour in a sufficient amount and allow it to work for about 10 minutes. Both of these agents will help to dissolve the earwax, and they both help to dissolve the cyanoacrylate. Repeat if needed to debond the cyanoacrylate from the ear canal. Irrigation. Irrigation is the default setting for non-organic foreign bodies that you just can't get out with other extraction techniques. Sometimes the object is encased in cerumen, and the only instrument that will fit behind the foreign body is the slowly growing trickle of water that builds enough pressure to expulse it. Again, don't irrigate if there's any organic material involved. The object will swell and cause more pain, it'll be more difficult to extract, and you may set up the scene for infection later. To irrigate, position the child either prone or supine and gently restrain him. Let gravity do the work for you. Don't irrigate with the affected ear up. It may be more accessible to you in this position, but you'll never get the foreign body out. Have the child lie on his side. Take off his shirt and drape him with towels or absorptive mats. You have the time, so be nice. You can use a butterfly needle to irrigate. Take a small gauge butterfly, so 22 or 24 gauge, cut off the needle and connect the tubing to a 30 ml syringe that you've filled with warm or room temperature water. Insert the free end of the tubing gently and secure the tubing with your pinched fingers while irrigating it. Think of holding an ET tube in place just after intubation and right before you have to tape it or secure it. Gently and slowly increase the pressure you exert as you irrigate. talk to the child and make it fun and distract him. Have you ever had a dolphin whisper into your ear? You're in luck. Here we go. Well, what did he say? Wasn't that fun? You can also use an IV or angio catheter. Use a moderate size, so an 18 or 20 gauge IV. Remove the needle and attach the plastic catheter to a 20 ml syringe and irrigate, again, being kind and using warm or room temperature water. Acetone. Is there chewing gum or styrofoam or even super glue stuck in the ear canal? You can use a simple acetone solution. Just ask your hospital pharmacist. Make sure that the patient isn't at higher risk for perforation of the tympanic membrane. The inner ear and acetone just don't mix well together. Docusate sodium. Cerumen is composed of sebaceous and ceruminous secretions in desquamated skin. We can use a cerumenolytic, such as docusate sodium, also called cholase, to help loosen and liberate the foreign body. It's basically liquid soap. Here's a little note. Adding docusate sodium will make the object more slippery. So if you have a child with, say, pebbles or sand in his ear, and loosening the earwax may aid extraction and not cause a slippery mess, think about filling the ear canal with docusate sodium. Have the child lie with his affected side up, wait about 15 minutes after you put it in, and then proceed. This is especially helpful when you're planning for some kind of irrigation. Magnets. Rare earth magnets are not actually rare. They're everywhere. An example of a powerful rare earth magnet is neodymium of the buckyball magnet fame we just talked about. We can use its magnetic superpower for good now, to help retrieve metallic foreign bodies like button batteries in the nose or ears. Another option is a magnetic pickup tool. It's a small magnet at the end of a telescoping handle used by mechanics, by engineers, and do-it-yourselfers. They're inexpensive and readily available in various sizes, shapes, and styles. Look for one with a small tip diameter so that you can fit it in the ear canal or in the nose, and one with a strong hold. They're sold in pound holds, so get one with at least a 3-pound hold. Alternatively, you can purchase a strong neodymium bar magnet, one with a 30 to 50-pound hold. Attach the magnet to any metallic instrument to make it into a supercharged magnetic extractor. You can use a magnet with, say, alligator forceps, with pickup forceps, or a small hemostat. Although stainless steel is often said to be non-magnetic, it depends on the alloy used, and some may actually respond to the strong, rare earth magnet. Most stainless steel has a minimum of 10.5% chromium, which gives the steel its stainless properties and essentially its corrosion resistance. Okay, here's the nerdy explanation. Basic stainless steel has a ferritic structure, like iron, and it's magnetic. Higher-end stainless steel, such as what you would find in kitchen cutlery, have an austenitic or heat-treated structure with more chromium added, so it has less magnetic quality. Ironically, the more, shall we say, economical instruments that we find in our typical ED suture kit have less chromium, and so they're more magnetic. You can use these with your neodymium bar magnet to conduct the magnetic charge and extract the metallic foreign body. The bottom line: if it's metal, it's worth a try to use a magnet. Even if the metal is very weakly magnetic, the strong neodymium magnet may still be able to exert a pull on it and aid in extraction. The snare technique. The snare technique is a relatively new method described by Fundakovsky et al. Basically what you do is you take a small length of 24 gauge wire or something similar. You can get it at your local home improvement store or even online. Cut a small length with your trauma shears. Make a loop and secure it with a hemostat. That's it. Now you have a snare that you can pass easily behind a tricky foreign body. You can maneuver it to engage with the side of the object and pull gently. Here's how to do it step by step. Treat the ear with lidocaine, either 1 or 2% solution topically, or you can treat the nose with oxymetazoline. Pass the loop behind the foreign body. Pull the loop toward you until you feel that it's sitting up against, let's say, the button battery. Now, turn the hemostat 90 degrees to improve your purchase on the foreign body. Pull it out gently. This technique is especially useful when the foreign body has created marked edema, either creating a vacuum effect or making it difficult to pass other instruments. Balloon catheters. These, I have to say, are a godsend. I have no connection to these guys, but do yourself a favor and get your department some CATS extractors if you don't already have them. Before the CATS extractor was commercially available, if you were lucky, you may find a Fogarty embolectomy catheter, let's say in sizes 5, 6, or 8 French, but it was so hit and miss to find, and they were extremely expensive. The CATS extractor was designed specifically for foreign body removal. It's a thin, soft, but sturdy plastic catheter with a syringe on one end that you can blow up the small balloon on the distal end. This is how you use it. Inspect the ear or nose for potential trauma and to anticipate bleeding after manipulation. Deflate the catheter and apply surgical lubricant or 2% lidocaine jelly. Insert the deflated catheter and gently pass the device past the foreign body. Inflate the balloon to gentle resistance and slowly pull the balloon and foreign body out. Reinspect after extraction. Just a little caveat from the manufacturer of the CATS extractor, In Health. Quote, "The CATS extractor otorhino foreign body remover is intended principally for extraction of impacted foreign bodies in the nasal passages. This device may also be used in the external ear canal based upon clinical judgment." Unquote. Mother's Kiss. The mother's kiss was first described in 1965 by Vladimir Tsibor, a general practitioner from New Jersey. He described it in this way. The mother, or other trusted adult, places her mouth over the child's open mouth, forming a firm seal as if about to perform mouth-to-mouth resuscitation. While occluding the unaffected nostril with a finger, the adult then blows continuously until feeling resistance caused by closure of the child's glottis, at which point the adult gives a sharp exhalation to deliver a short puff of air into the child's mouth. This puff of air passes through the nasopharynx, out through the non-occluded nostril, and, if successful, results in expulsion of the foreign body. The procedure is fully explained to the adult before starting, and the child is told that the parent will give him a big kiss so that the minimal distress is found to the child. The procedure can be repeated a number of times if not initially successful. The mother's kiss sometimes needs a little coaching, but you can usually tell which mom or dad is up for the challenge. Positive pressure ventilation with bag valve mask. Okay, so maybe mom or dad wasn't up for it. We can do the same thing as a mother's kiss using the self-inflating bag. Sit the child up. Find a very small mask that will only fit over the child's mouth. Now, this goes against everything I've told you about ventilation, but here we're not trying to ventilate the child. We're just trying to get a seal around the mouth itself, leaving the nose clear. You can use a neonatal mask. When you puff air into the mouth of the child, he'll reflexively close his glottis, and the pressure backs up behind the foreign body and pushes it out the nose. Occlude the opposite nostril with your finger while you form a tight seal with the mask around the mouth. Deliver short, abrupt bursts of ventilation through the mouth. Be sure to maintain good seals with the mask and with your finger to the child's nostril until the foreign body is expulsed through the affected nostril. You may have to coax and try a few times, but with some planning, reassurance, some gentle restraint, and persistence, you'll often get it out. The Beamsley Blaster Technique. For the very uncooperative child with a nasal foreign body amenable to positive pressure ventilation who fails the mother's kiss and bag mask technique, a continuous positive pressure method can be used. Connect one end of suction tubing, not to the suction canister, but to an air or oxygen source. Just shove it right on the Christmas tree adapter. Connect the other end of the suction tubing to a male-to-male adapter. This is the one that you'll find in the chest tube kit to connect the chest tube to the pleural vac. So now you've converted the large diameter suction tubing to a source of continuous positive pressure. At its end, you have the tapered male-to-male adapter that will fit in the child's unaffected nostril. The airflow will deliver positive pressure ventilation continuously. Give the child a break every 10 to 20 seconds by taking the adapter out and then reinserting. With this technique, there is a theoretical risk of barotrauma to the lungs or tympanic membranes, but there's only one case reported in the literature. It was periorbital subcutaneous emphysema. To minimize this risk, some authors recommend limiting to a maximum of 4 attempts using any positive pressure method. A few more tools of the trade. The Nasal Speculum. Optimize your visualization with a nasal speculum. The nostrils, luckily, will accommodate a fair amount of distension without any harm. Hold the speculum vertically to avoid pressure and damage to the vessel and nerve-rich nasal septum. Stand on the affected side. Hold the handle of the speculum in the palm of your hand comfortably while placing your index finger on the patient's ala. This will help you to control the speculum and your angle of sight. Your other hand is then free to use a hook or any other tool for extraction. Remember, you're opening the speculum north-south. This way you can distend the nostril without discomfort. Lighting is especially important when using the nasal speculum. A focus procedure light or a headlamp is very helpful here. Suction tips and catheters. Various commercial and non-commercial suction devices are on the market for removal of foreign bodies. All connect to wall suction and they all vary by their style, their caliber of suction, and the tip-end interface. A commonly available suction catheter is the Fraser suction tip, a single-use device used in the operating room. It has a diameter tip that can lock on to those little foreign bodies. You can modify any suction catheter with the Shook-necked foreign body remover. It's a plastic cone-shaped tip placed at the end of a suction catheter to increase the vacuum surface area and seal. The laryngoscope and McGill forceps. If a child aspirates and occludes his airway, return to BLS maneuvers. If the child becomes obtunded, use direct laryngoscopy to visualize the foreign body and remove with the McGill forceps. Hold the laryngoscope in your left hand as usual. Hold the McGill forceps in your right hand. Remember, palm side down. You can use them then to grasp and remove the foreign body. Just remember to look again afterwards. Now we're ready for any ENT enemy invaders, foreign or domestic. Here are some take-home points. 1. Beware of the vacuum palate. A flat, especially clear plastic foreign body can be pegged up against the hard or soft palate, later becoming an airway foreign body. 2. Take seriously the complaint of foreign body without obvious evidence on initial inspection. Believe that something is in there until proven otherwise. And 3. Control the environment, address analgesia and anxiolysis, and have a backup plan. And lastly, check out the show notes for a few addenda about talking to parents about child safety and prevention. This ED visit may be a sentinel event. Take a minute to get the parents thinking about food and home safety. Thank you for listening. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.